Hello, welcome on behalf of the Mountain Plains Regional Disaster Health Response System. This is the 8th in our series of modules of Be Nice Weapons of Mass Destruction presentations. In this module, we're going to discuss incendiaries and explosives. My name is Dr. Peter Pons, and I'm an emergency physician in Denver, Colorado. We're going to talk about the common incendiaries and the injuries associated with them. We're going to talk about blast injury and the pathophysiology of the various types of injury. And we're going to outline the management of victims of blast injury. This is a list of the common incendiaries: magnesium, white phosphorus, and thermite, which is a metal powder with metal oxide. All of them are highly flammable. All of them generate extremely high temperatures, and all obviously will result in burn injury. Magnesium, it's a metal, comes powdered or solid, burns at extremely high temperatures. It'll react with water to produce hydrogen, which itself can be explosive. Inhalation of burning magnesium can produce a respiratory burn, leading to cough, increased respiratory rate, hypoxia, wheezing, pneumonitis, and airway burns. And obviously, since it reacts with water, any particulate debris that is seen in a patient should be removed prior to irrigating of any wounds. White phosphorus. This is a solid material which ignites spontaneously when exposed to air. It's the material that's used in road flares, burns at high temperature. Obviously, because it ignites when exposed to air, affected areas should be immersed in water or saline. Oily or greasy dressings should be avoided because any retained white phosphorus is lipid soluble and will be absorbed and then cause systemic toxicity. Thermite, an example is powdered aluminum and iron oxide. It's difficult to ignite. Magnesium is actually used to ignite the thermite, burns at high temperature, scatters molten iron, and basically you want to cool any burned areas and remove any contaminated debris. Everyone should be familiar with the burn classification, the old categories being first degree, second degree, third degree, and fourth degree. Now, of course, we refer to them instead as superficial, partial thickness, and full thickness. Management of a burn injury from an incendiary: standard burn care, stop the burning process, remove any smoldering clothing, remove any constricting items, assure that their airway and ventilation and oxygenation are being maintained and are adequate. Obviously, anytime there is a burn injury with potential inhalation injury, consider the potential need for endotracheal intubation. And if it needs to be done, it needs to be done early rather than later, because as swelling progresses, the intubation becomes progressively more difficult, and early intubation is a lot easier. And then patients need to have their volume status maintained to assure adequate hemodynamic stability. There are a number of ways to calculate how much fluid is necessary for these patients. Parkland formula perhaps is one of the most common. The military developed a process called the rule of tens to make it easier. And of course, you can just provide fluid to maintain urine output. And then, as you might guess, any patient who has sustained major trauma and also has a burn, the trauma takes priority over the burn management. The burn management is a secondary consideration in these patients. Now, explosions and blast injuries. An explosion is the
types of explosives. They all work by releasing energy. In this pipe bomb, the energy begins to build when the gunpowder is ignited. Burning forces the powder to change form from a solid to a gas. The gas builds up inside until the pressure is so great that even a solid steel pipe bulges until it can no longer hold together. This explosion was filmed in extreme slow motion, 1,000,000 frames a second.
So as you can see from that video, an explosion is an instantaneous chain of events in which whatever the explosive material is, typically a solid or a liquid, it is rapidly converted into a gas under high temperature and high pressure. When this occurs, we generate a change in pressure called a Friedlander wave. And here at time 0, the light blue arrow, you see that's the time of detonation. As that material converts from a solid or a liquid into a gas, pressure increases. And we have a phenomenon called blast overpressure. Then we see decay of that pressure. And this entire period is called the positive pressure phase. And then we have the negative pressure phase and a return back to normal. Now, if you think about this sudden increase in pressure as the explosive detonates, we have this massive increase in pressure. And what that does is it blows all of the air out in the area immediately adjacent to the explosion. That creates this relative negative pressure. And eventually, once the pressure has decayed, the air that was blown out comes rushing back in to normalize the pressure. This is an atomic explosion, and you'll see the positive pressure phase and the negative pressure phase. There's the positive, there's the air rushing back from the negative pressure phase. Here's the positive again, and then the negative. And again, and you can see the heat generated by this explosion as it burns off the paint. Positive phase, negative phase. Now, the blast wave properties will affect the extent of the injury that someone exposed to that blast wave will sustain. The size of the blast overpressure obviously is a key component, and how much pressure an individual is exposed to. The duration of the exposure to that positive pressure phase. Did this occur in an enclosed space or an open air space? As you might guess, in an enclosed space, the pressure wave is contained within that space, whereas in an open air detonation, that pressure wave disseminates outward 360 degrees and is less damaging to the individual. Are there reflecting surfaces? And we'll talk about more about that in just a minute. What is the media in which the explosion occurred? For instance, an explosion occurring in water, which is denser than air, will propagate the explosion to a greater extent than it does in air. And how close are you to the explosion? Obviously, tissue susceptibility is related to distance, and the farther away you are, the less damage that will occur. In terms of pressure and injury, it only takes 2 to 5 pounds per square inch to rupture an eardrum. 15 pounds per square inch is enough to damage lungs, and 30 to 40 pounds per square inch is the lethality threshold. And associated with this blast wave is a blast wind. And that's what happens when the expanding gas from the explosion displaces air immediately around it. And depending on the explosive, that blast wind can have speeds up to 1,200 to 1,500 miles per hour. Now think about the average run-of-the-mill tornado, or think about the average run-of-the-mill hurricane, where we're talking winds of 100 to 150 miles an hour. This is 10 times that. Well, bombings are certainly not new. We have had our share of these in the US. You can see that we have had literally thousands of bombing incidents with a number of injured and deaths. In recent history, 2004 to 2012, if you look at the number of explosives related incidents, we average about 4,000 incidents a year with about 50 injuries and an average of about 10 to 15 deaths as a result. These are European attacks, and the size of the circle represents the number of fatalities. And again, you can see, this is not a unique phenomenon. These are photos from the Madrid train bombings in 2004. There are multiple locations that were bombed, multiple casualties, as you can see. Of course, we had our bombing in 2013, the Boston Marathon bombing, in which an improvised device was prepared using a pressure cooker with lots of shrapnel, resulting in a number of deaths. So while we're focusing, as always, on terrorists, there are lots of other ways that blast injuries can occur. And while we have the military and landmine explosives, fireworks, almost every year we see a report of fireworks that misfired, causing casualties, industrial accidents, utility accidents, overfilling of tires causing explosions and injuries. And for those of you that like to brew beer, we've had some brewing mishaps as well. So the types of explosions can be mechanical, chemical, or nuclear. The mechanical ones are things like overfilling of the tire. Chemical are the standard explosives that we talk about, and nuclear, of course, being self-evident. So blast injury and blast mechanics relate to the explosive itself. And we talk about high energy explosives and low energy explosives, sometimes referred to as high order and low order. High energy explosives detonate faster than the speed of sound. Low energy explosives detonate slower than the speed of sound. The high energy ones, it's a true detonation. Low energy is much more of a burning process. The only explosives that will produce that blast overpressure are the high energy explosives. So if we look at our list of explosives, low order are black powder, gunpowder, that sort of thing. High order explosives also fall into two categories, primary and secondary. Primary high explosives are those that can detonate without the need for something to set them off, a starter, if you will. Secondary high explosives are those that require a starter explosive to then detonate the explosive itself. Now, we'll show you an example of deflagration. This is a low order explosive. Now, in spite of how it sounded, that is in fact a low order deflagration, slower than the speed of sound. This is C4, so it's detonation of a high order explosive. And you see the difference in damaging as a result of these two. Now, a solid surface will reflect the force, and you see that in this video. When the explosion happens, the force bounces back and forth between the reflective surfaces, and that can actually increase the damaging effect of a blast wave up to 9 times. This is part of the reason why explosions in enclosed spaces are much more damaging to an individual than explosions that are open air. If we talk about explosives, dynamite is probably the most common one. It's used extensively in blasting operations. It comes in a wide variety of formulations that differ in their explosive content, and it's relatively easy to get, relatively easy to steal. It also can deteriorate and potentially cause problems by detonating. Ammonium nitrate, fertilizer. This is pretty insensitive, but it is a readily available secondary potential high explosive. Comes as primarily small compressed pellets or pills, and it's used in some dynamites. And as I said, it's a fertilizer. Ammonium nitrate mixed with fuel oil. This is the fertilizer mixed with diesel fuel. You do require something to set it off, but you saw how effective this could be as a high order device in Oklahoma City with the bombing of the Murrah building. And then TATP and HMTD, these are liquid explosives. This was the UK airplane plot in which the terrorists brought aboard peroxide and acetone in separate containers, wanted to mix it together to create the TATP. Small amounts of TATP actually burn when it's ignited. More than 2 grams will explode when ignited. And we have our share of lower order devices that are improvised: pipe bombs, vehicle bombs, backpack, briefcase bombs, etc. For those of you who remember when we had the Olympics in Atlanta in 1996 at Centennial Park, there were a couple of backpack bombs placed in which shrapnel, such as the nails shown in this image, were included and caused a number of casualties. 1 detonated, and I believe 1 was found. Now, in terms of IEDs, instructions to make them have been widely published on the internet. Inspire magazine, which is the English language publication of Al-Qaeda, has published a number of articles on making bombs. And I think everyone who is a responder in the field needs to be prepared for this potential kind of incident. And as always, if one bomb is either found or explodes, someone should be conducting a search for that secondary device that would be targeting responders. The photographs show the titles of 2 of the Al-Qaeda articles. The ongoing series is titled "Make a Bomb in the Kitchen of Your Mom," the Al-Qaeda chef. The first one is pressure cooker bomb, which obviously was the device that was used in Boston. The second article is car bombs inside America. And you may recall there was an incident in Times Square in New York City a number of years ago in which a car bomb was prepared, but instead of detonating, it sort of smoldered and was then appropriately dealt with. This is a quote from the car bombs article. This recipe gives you the ability to make a car bomb even in countries with tight security and surveillance. The reason is the primary materials are easily available and they don't raise suspicion. They're not explosive in nature, but once you've assembled and prepared them, they turn into a bomb ready for destruction. Praise Allah. This type of bomb is not used to destroy buildings. However, it is very effective in killing people. The merit of this method is that you can prepare your car bomb in a few hours. The article then gives you a complete list of what you need to purchase in order to make the bomb. It also provides a list of potential targets in the US. And here is some of that list. And it's not only the US, it's also elsewhere in the world. Well, let's talk about the mechanisms of blast injury. It's traditionally divided into several different types: primary, secondary, tertiary, and some include quaternary. Primary blast injury is the direct effect of the blast wave on the victim. Secondary blast injury is when objects strike the victim, so typically you would expect penetrating trauma from the shrapnel. And tertiary blast injury is when the victim gets thrown by the blast wave and the blast wind, striking some stationary object, causing blunt trauma. So primary blast injury, it's the propagation of the blast wave through tissue. And as a reminder, primary blast injury will only occur with high order explosives because they're the only ones that create this blast overpressure. The incidence of primary blast injury varies significantly depending on the reference that you look at. The nature of the injury obviously relates to the size and duration of exposure to that blast overpressure. As I mentioned before, there's a higher incidence underwater and in enclosed spaces because of the reflection in the enclosed space. And this sudden increase in pressure that the tissue gets exposed to is primarily going to affect organ systems with high air content. So auditory system, the eardrum, pulmonary system, and the GI system. Secondary blast system results from objects being displaced or thrown by the overpressure, by the blast wind, by gravity. We're talking shrapnel. And, it may be from whatever was blown up. It may be additives such as nails, screws, nuts, ball bearings into the bomb designed to cause more injury. And the result, as you would expect, is primarily penetrating trauma. Tertiary blast injury results from the victim being displaced by the blast wave and wind. They get thrown into some object and you see blunt trauma. You may also see amputations, and we see traumatic brain injury. So there's a significant incidence of immediate and very early death. And then there's a bunch of miscellaneous injuries that don't fall nicely into those first three categories, often referred to as quaternary blast injury. And this includes burns as a result of the explosion, or if there was a chemical additive, if there was radioactive material added in, radiation exposure, inhalation injury as a result of smoke and toxins that might result from the explosion, all fall into this category. Now let's talk about specific injuries and specific body systems and their potential management. The ear, the tympanic membrane, one of the more common organ systems that's damaged, again, quite variable in terms of what's been reported in the literature in terms of incidence. It's the organ that is most susceptible to primary blast injury because it requires the lowest level of blast overpressure. Hearing loss is common after one of these explosions, maybe temporary, maybe permanent, and you may see that ruptured eardrum. It has been suggested that looking for a ruptured eardrum is an indicator of other forms of primary blast injury, meaning the lung, the GI tract. Okay, and that intact eardrums mean there's a low probability for serious primary blast injury. But this hasn't worked out quite as nicely as one would hope as a screening tool. The eardrums are relatively easy to protect. And in one study that was done about 20 years ago, no patients exposed to a blast injury that had a tympanic membrane rupture developed a blast injury. But 18 of 31 patients who had blast lung injury had intact tympanic membranes. So, you know, if you see it, it tells you that, in fact, they did get exposed to blast overpressure. If you don't see it, it does not rule out the possibility of other primary blast injuries. The lung incidence of primary blast lung injury ranges from 1% to about 40%, and relates primarily to the conditions. Much higher incidence in confined space explosions, again with that reflected blast wave. Okay. It's a common finding in those who die from the explosion, and it's a common cause of delayed mortality. You see alveolar wall damage and interstitial and interalveolar hemorrhages and edema. You may see pneumothorax, hemothorax, pneumomediastinum from pleural tears. You may see disruption of bronchi and vascular structures, allowing for air to enter the pulmonary veins and embolize, causing air embolus. So blast lung is a clinical picture of hypoxemia, tachypnea, pulmonary hemorrhages on chest x-ray. And the interesting part is that you find the appearance on chest x-ray, but the external chest wall looks pretty much undamaged. So do not count on signs of external trauma to guide you as to whether or not blast lung could be present. And it may develop over a day or two and progress to full respiratory failure. Consider air embolism, because that is a possibility. Because the alveoli are leaking, don't overhydrate them. You don't want to create a pulmonary edema situation. Ideally, you would avoid positive pressure ventilation because of the risk of creating a tension pneumothorax. But if needed to maintain oxygenation, you should not hesitate to intubate and ventilate the patient, and just be prepared to manage a tension pneumothorax in the event it develops. And then keep a close eye on the patient for the development of ARDS. Air embolus, common cause of immediate death after an explosion, common in patients with pulmonary blast injury. And the air embolus can affect essentially any organ system. The eyes, retinal vessels, focal neurologic findings looking like a stroke, the tongue, the skin, and of course, air embolus to the heart can cause dysrhythmias and evidence of ischemia. Treatment, as always, is provide supplemental oxygen and try to limit any further embolization. Left lateral position with the head down, injured lung in the dependent position if possible, minimize the patient's movements, minimize positive pressure ventilation, which could further exacerbate air embolism, and depending on the severity, consider transport to a hyperbaric chamber if it's available to you. Central nervous system, most of that trauma is from secondary and tertiary blast injury. Again, a fairly significant incidence. Traumatic brain injury, you name the traumatic brain injury, it can happen along with skull fractures. Cerebral air embolism can occur. Pediatric patients may be more susceptible because their skulls have not yet fused and are not as strong as ours as adults. And sinus fractures can cause anosmia, and that may be noticed as well. The GI system, air-filled, so not insignificant incidence. Higher incidence in underwater and closed space blasts. Once again, air-filled organ, reflected waves, blast waves, damages those. The problem with these is that the other injuries, particularly pulmonary blast injury, tend to overshadow the finding of the GI injuries. GI injuries tend to take longer to present. So the other injuries tend to take precedence. You can see bowel wall contusions, perforations. You might see mucosal and submucosal hemorrhages, solid organ injury, spleen and liver, ruptures, hematomas, etc. How do you manage these? Exactly as you would for any other abdominal trauma patient. So that's no different. Cardiovascular system, you may see cardiac dysrhythmias, you may see cardiac contusion, ischemia from air emboli, and acute cor pulmonale as a result of elevated right heart pressures from lung damage. And finally, fractures, frequent injuries, as well as soft tissue injuries, and amputations are not uncommon, as you might expect. So, most common injury from incendiaries is burns. And your care, both pre-hospital and hospital, is standard burn treatment. Injury from explosives falls into 4 categories. Primary, which only happens with the high order explosives, affecting mostly the air containing organs. Secondary, which is mostly penetrating. Tertiary, which is mostly blunt. And blunt and penetrating trauma, standard management for those patients. Quaternary injury is everything else that can be associated with it. And trauma care, if you know how to take care of a trauma patient, you can take care of a blast injury patient. Thank you for participating in this module, and hopefully you'll take a look at some of the additional modules we've prepared on weapons of mass destruction.